All right, so what is acidosis of your blood? What is that? That's what I'm going to talk about today. And this episode might be a little more advanced for non-medical people. I will try to keep non-medical people in mind as I talk, but this may be more geared towards medical people. Feel free to listen, but if you're non-medical, you can bail anytime on this week's episode, but you might find it interesting. So let's go. All right, so what does acidosis means? Acidosis is more protons in your blood, more H plus protons in your blood. That's what acidosis is. Those protons have to come from somewhere. So in a normal patient's pH, so pH is a measure of your acidosis, right? And if you recall, if you took some chemistry, basic chemistry in high school, a neutral pH is 7. And that's in between that's measuring how many protons are in a solution. That's what pH measures. So the human blood, your normal pH that you are required for normal, cellular processes, 7.4. That's the gold standard value. And the acid-base status of your blood and your cells is so extremely important because that dictates how metabolism happens, enzymatic function, how proteins interact with one another. They must have the correct milieu to be able to function. And if you become too deranged, if you become too acidotic, your cellular metabolism and your functions can shut down. And that's why your body is extremely, extremely good at keeping that pH at 7.4. Now, when patients are critically ill, they often become acidotic. So their pH drops. Now, it doesn't drop dramatically like it would in like a beaker dish or a beaker like in your chemistry class where you're dropping someone's acid, you're dropping a solution, the acidity of a solution from like 7 to 6 to 5. Those are way too dramatic for the human body. It must be close to 7.4. So like 7.3, you're acidotic. 7.2, you're acidotic. 7.1, you're quite acidotic. 7.0, you're extremely acidotic. 6.9, that's extremely acidotic. You're probably dying or you're already dead when your pH is that low. So that just kind of gives you some context if you're not familiar. So where does the acidosis come from? So if someone is really sick, let's talk about someone in shock. So what is the definition of shock? It's where your cellular metabolic demands are no longer met by the blood flow that is going to them. So when you go into shock, you have worse blood flow and your body can't compensate for that anymore. And then you start going into anaerobic metabolism where you start producing lactate more. Because if you recall, most of the powerhouse of the cell is the mitochondria, right? The mitochondria makes all that ATP. That's where all the power, the ATP is used to power all of these enzymatic processes that we're talking about. You need ATP, and the mitochondria produces that. And the mitochondria can only function if it has an appropriate, adequate supply of oxygen. So if you're in shock, your tissues are no longer being well perfused. You're not getting delivery of oxygen by your hemoglobin, and now all of your metabolism is being shunted into anaerobic metabolism, which is where lactate comes in. Lactate can be used as like your plan B for your cells to continue to make energy. The lactate gets shuttled back to your liver. Your liver uses something called the Cori cycle, and it turns that lactate back into glucose. And glucose can also be used to make energy. Not quite as much as the Krebs cycle, sorry for bringing up that word, and that's not quite so much as the Krebs cycle within the mitochondria. But the glucose can still make some ATP, and so you can still live a little bit with lactic anaerobic metabolism. So let's go back to my question. What causes this acidosis? So your lactate starts going up and your pH starts going down. Suddenly your pH is 7.1, your lactate's up. Did you somehow dump more protons into your body? No. So where did those protons come from? They came from the water that's already in your body, right? The human body is mostly water. And water is in an equilibrium between hydroxide and hydronium, if you recall that from chemistry. Again, this might be annoying to people that haven't taken these courses. But my point is, water is in equilibrium between hydronium, hydroxide, and water itself, right? It's this equilibrium flux. And that flux can be tilted off course by changing the electrochemical makeup of what's going on. And so the protons actually come from water. They come from a derangement of that equilibrium, and protons start getting dumped into the solution and they become acidotic. Water provides an inexhaustible source of protons. Acidosis does not occur because total body protons increase. pH changes occur as a consequence of water dissociation into protons and hydroxide. Hydroxide, if you recall, is oxygen, hydrogen, and together. And water dissociates into acidosis, into a proton, from three things. Increasing your carbon dioxide, the addition of weak acids, and that means, so proteins are acidotic, and that can also be dependent on your metabolic state. And then the third thing is the strong ion difference. Now, if you're a medical person, or if you're a med student and you just heard the strong ion difference, I can hear you groaning right now. One of my goals is to demystify the strong ion difference to you. It's pretty straightforward if you just kind of build up. The strong ion difference is an important model. I don't think it's like a perfect thing, but it's an important model to understand how acidosis works. So let's take a small detour into the strong ion difference. And if you're non-medical, I don't blame you for hopping off right now, but feel free to join along the ride if you're getting something out of this. All right, so the strong ion difference, to understand it, just remember this one thing. Blood chemistry always seeks electrochemical neutrality. What does that mean? Well, there are cations and there are anions in your blood, right? There are positive ions and there are negative ions constantly in your blood. Examples of cations are sodium and like potassium, and also protons, right? Those are positively charged. And then major anions in your blood, there's like chloride and hydroxide. So there's all these cations and anions are jumbling in your blood at all times, right? And there's always a set amount of cations and there's always a set amount of anions. The strong ion difference is the difference between these two. The measured difference between, you take up all your cations, and you minus them from all your anions, and you have a strong ion difference. And that difference is 34 milliequivalents per liter at normal baseline. There's a difference between how much there is between these two things. Okay, and so the body is always seeking out this natural electrochemical neutrality, or this natural, and the body does not want charge across the solution of your blood. There shouldn't be a charge difference between the two. So the way your body adjusts for this is it either dumps in more protons or it dumps in more hydroxide ions. More protons are cations, hydroxide are anions. So it dumps these in back and forth to seek electrochemical neutrality. That is always the goal of the chemistry of your blood. It wants the electrochemistry to be neutral. And the way it does this is water flexes. It either flexes as a proton or it flexes as a hydroxide. So, for example, if you dump a bunch of chloride into your blood from getting a bag of sodium chloride, you now have a bunch of anion that's in your blood. And in order to seek electrochemical neutrality, the water will then, flex into dumping protons into your blood. And now you have more protons than normal. And what is acidosis? Having a higher concentration of protons than normal. And that is why you're acidotic. Does that make sense? Let's take the opposite example. Let's say you have been throwing up all night and you lose a bunch of chloride because you threw it out. You lose a bunch of chloride through your gut. And now you have less chloride in your blood. Well, the water flexes and now it dumps a bunch of hydroxide to equal out that chloride. And what is the definition of being alkalotic? Having a higher concentration of hydroxide in your blood. So now your blood is alkalotic. That's it. Your body constantly seeks out electrochemical neutrality. So the change in pH, or the change of proton concentration, is a consequence of water dissociation in response to a change in this strong ion difference. Okay, so that's a little bit of strong ion difference. Let's go back to that. There are three causes of acidosis, right? I talked about carbon dioxide, which is controlled by your respiratory system, the strong ion difference, which is the electrolyte composition of your blood, and that's also controlled by your kidneys. And then overall increased concentration of acids, which can be increased from a protein concentration, and that is controlled by your current metabolic state, by your liver and your kidneys. So a change in any of these three things, these are dependent variables of pH. Those are independent variables. There are dependent variables of pH. So the actual protons, concentration of protons, that's dependent, right? That's not the cause of acidosis. That's the dependent. That's dependent on something else. Hydroxide ions, bicarbonate, and other acids and bases that are in your blood. These variables change, and they change as a response to independent variables, which are, again, the independent variables are the concentration of your carbon dioxide, the strong ion difference, and how many weak acids you're actually adding to your system. What I've just explained to you is the Stewart's model. This is the Stewart approach, as opposed to the Henderson-Hasselbalch approach, which is based on the classic equation, the Henderson-Hasselbalch equation. The Henderson-Hasselbalch equation only deals with, that's where we get base excess, correcting a base excess, which is a way of correcting your metabolic pathway or correcting your respiratory acidosis, which is correcting your carbon dioxide with ventilation. I believe the Stewart's approach is more nuanced than the Henderson-Hasselbalch. I'm not someone that just goes and corrects every base excess that I see. I actually think it's kind of pointless. And that might be too much of a nuanced discussion even for what I'm talking about right now. So let's get to blood buffering. How do you buffer your change in acidosis? Buffers have conventionally been defined in acid-base chemistry as substances that allow a solution to resist a change in pH in response to administration of proton. So should we buffer? Because we understand poorly both the effects of an elevated arterial concentration of protons as well as the effects of attempting to correct it, deciding whether to administer a buffering agent such as sodium bicarb to patients with non-bicarbonate losing forms of metabolic acidosis is a difficult thing to do. Proponents of such an approach to correct your acidosis with sodium bicarb, they typically argue along the following lines. Acidosis is in itself harmful. Administration of a buffer will lower your proton concentration. Lowering your proton concentration will provide clinical benefit, and any adverse effect of a buffer is outweighed by that benefit. So is acidosis harmful? It is. We talked about that. But it's to a certain degree. Acidosis is both it's both protective and maladaptive. So if you recall from your oxygen dissociation curve, those of you that know what I'm saying, if you recall, if your blood becomes acidotic, your hemoglobin more easily offloads oxygen into your tissues. And this makes sense. This makes absolute sense. When you think about a patient's body that's in shock and their tissues are underperfused and they're not getting the supply of oxygen that they need, the acidosis is a natural protective feedback loop that you become acidotic so that the blood that does get there, it offloads the oxygen faster and easier so that those vulnerable tissue beds can still get that oxygen. So that's how it's protective. But acidosis can also be maladaptive. So this can go off the rails, this process, right? As you become sicker and sicker and more acidotic, if the underlying disease is not corrected. And so there's a cliff. Now, where is that? Where you become so acidotic that your cellular metabolism can no longer function. The enzymes and the proteins, they can't function anymore, and you fall off that cliff. We don't know where that cliff is. We don't. Some people like to act like they do, but they don't. They don't. Is that a pH of 7.2? I don't think so. Is that a pH of 7.1? Maybe. Is that a pH of 7.0? Probably. Is that a pH of 6.9? Yeah, it probably is. So acidosis is harmful, but it's also protective. That's something we need to remember. I allow permissive acidosis, and that's not just me talking. So does sodium bicarb actually raise the pH? It does. It will transiently raise the pH. But as I discussed before, bicarb is not an independent determinant of pH. Remember, there's three things that cause acidosis. Carbon dioxide, increase of carbon dioxide, the addition of weak acids, usually a high protein load, that's usually someone who's in renal failure, or the strong ion difference, the things that we talked about earlier. So if sodium bicarb administration raises pH, but bicarb is not an independent determinant of pH and readily converts to carbon dioxide, which is a topic I haven't brought up yet, how does it actually raise the pH? This will blow your mind. If you've been following me this far, what am I going to say will probably blow your mind if you don't know it already. How does bicarb actually work? How does sodium bicarb actually work? It's not the bicarbonate. It's the sodium. Sodium is a strong cation. Bicarbonate is not. Therefore, if you raise the strong ion difference by administering sodium, you lower the concentration of protons. When ventilation is not limited, bicarbonate reacts with protons, creating carbon dioxide and water. Carbon dioxide is then eliminated by the lungs. So it's not even the bicarb that's doing the buffering, which is, when I first learned that, really kind of blew my mind. Now, sodium bicarbonate administering can actually be harmful. Bicarbonate infusion has been shown to stimulate the production of lactate. You can actually aggravate lactate acidosis. Sodium bicarb results in a significant decrease of liver and erythrocyte pH, hepatic portal vein blood flow, cardiac output, and in significant increments of gut lactate production, whereas sodium chloride does not. Same results have been found that I'm talking about in hypoxia, DKA, hemorrhagic shock. All animals have worsening lactate in many, many studies after they've given sodium bicarbonate. And then let's zoom out to the bigger picture. So when you're measuring a patient's blood pH, you're measuring their intra-arterial, or typically their intra-arterial pH. So you're getting a sample of their bloodstream. How accurately does that reflect the intracellular pH, which is the enzymatic activity that we actually care about? Now, we do care about serum enzymatic activity. Obviously, many, many processes happen there. But how reflective of the intracellular pH, how reflective is like getting an ABG with that extracellular pH, the intravascular pH? How well does that correlate with the intracellular? It doesn't. There's been some MRI studies that have shown that the two do not necessarily correlate. All right, so when should you actually give sodium bicarbonate? When is it indicated to give sodium bicarbonate to correct someone's pH? I'll cut to the chase a little bit. There are very, very, very few evidence-based guidelines that say, yes, give sodium bicarb. And it's given way, way more than guidelines say. So there's like 4 scenarios to give sodium bicarb. When someone has diarrhea, when they're actually losing bicarbonate through their GI tract, you should give them sodium bicarb. They may need an infusion. They may need tabs. Renal tubular acidosis. You're now losing bicarbonate through your kidneys. Intolerance of an acid load in CKD. So if someone has CKD, they're not tolerating their dietary acid load from proteins, and giving them sodium bicarb may prevent progression of their kidney disease. And then tricyclic antidepressant overdose. Those are the indications. All other indications, lactic acidosis. Many independent studies have shown it is not effective to give sodium bicarb during lactic acidosis. There's been some studies that showed that it actually affected mortality. I don't know if that's true. I'm not gonna say that because that's a hard thing to tease apart, particularly because a lot of people that die probably get sodium bicarb just by correlational. If someone is in acidosis from diabetic ketoacidosis, there's no reason to give that person sodium bicarb. You correct their underlying disease, which is obviously their ketoacidosis. There's been studies that there's no evidence to justify the administration of bicarb for someone with emergent DKA. With sepsis, so the Surviving Sepsis campaign, which is like what we should all be following in critical care, here's literally a quote from them. Not using sodium bicarbonate therapy for the purpose of improving hemodynamics or reducing vasopressor requirements in patients with hypoperfusion-induced lactic acidemia with pH greater than 7.15. They basically say if they are at a pH of 7.15 or higher, don't give them sodium bicarb. Permissive acidosis actually may be helpful for patients. And do you have any idea how much it would revolutionize medicine if we could prove that a low acidosis could actually benefit mortality? It would be revolutionary. Now, if you're following me along this far, you might be like, well, what about the Bicar ICU trial? I'll just explain my critiques of that. That's an open-label, multi-centered RCT involving 300 patients. They used a Bicarb 4.2 infusion compared to a control. The primary outcome was a composite of all-cause mortality at 28 days, or the presence of organ failure. There was no difference in mortality of all comers, but they say there was a statistical significant mortality in patients with AKI. They say that bicarbonate reduced the need for dialysis from 52% to 35%. Among patients who received dialysis, bicarbonate delayed the initiation of dialysis by about 12 hours. So people use this trial, the Bicar ICU trials, to say like, oh, it'll prevent people from going on dialysis. Here's my first response to that. What's one of the main reasons people go on dialysis? Acidosis. What corrects acidosis on dialysis? Sodium bicarb. That's in the dialysate bath, right? So when someone says, oh, this trial proved that sodium bicarbonate made people not get on dialysis, all I'm hearing is sodium bicarbonate prevented people from getting sodium bicarbonate. It's not a reasonable conclusion to make. The problems with the Bicar ICU trial is it was underpowered. The study was powered to detect a 15% difference in the primary endpoint based on a retrospective study that correlated acidosis with poor outcomes. Overestimation of the effect size led to an underestimation of the number of patients needed for the trial, causing the entire trial to be underpowered. They removed patients that the clinicians judged to to definitely need bicarbonate, and that skewed the trial populations towards patients who might benefit less from bicarbonate, and that increased the likelihood of a false negative result. And then there was tons of crossover. 24% of patients in the control group received sodium bicarb, violating the study protocol. And the study didn't differentiate between non-anion gap, metabolic acidosis, lactic acidosis, uremic acidosis, which probably limits the generalizability of the entire study. So what about during like a code blue? Cardiac arrest. Oh, give sodium bicarb. It's all the time. And I've given bicarb during a code. I'm not going to say that I haven't. But in the United States, sodium bicarb was taken out of the ACLS algorithm in the 1980s. That's how long it's been out of the algorithm for 40 years. Why are we still using it? So one of the reasons that sodium bicarb is still in such heavy use in critical care. Here's one of the main reasons. Okay, so for one thing, there's this myth that the pressors, when you have someone on pressors and they're dying and their blood pressure's in the tank, there's this myth that because they're acidotic, the pressors aren't working because of the acidotic environment. Now that may be true. It's based on very limited animal data, but it may be true. And it may be true that when you give sodium bicarb, that it helps the medications work better, so the blood pressure comes up. That may be true also. That may be true. And we all see it too. If you know what I'm talking about, someone's crashing, you and sodium bicarb, and their blood pressure goes up, almost always. It's transient, but it goes up. And then what do we think? We corrected the acidosis. So all that may be true. It may not be true. Here's what I know is true. Sodium bicarbonate is hyperosmotic. If you give anybody a hyperosmotic load, their blood pressure will go up. So just think about that. Okay, so here's questions that I want answered about acidosis and bicarb. Is acidosis ultimately maladaptive or is it productive? I talked about that. It's both. Where is that line? We don't know. How do we know that we're changing intracellular pH by raising arterial pH with bicarb administration? How do we know that we're not decreasing critical oxygen delivery by correcting acidosis to vulnerable tissues? How do we know that we're not attenuating a wanted physiological microvasodilation to those vulnerable tissues by correcting the pH? Is the associated decrease in ionized calcium harmful or underappreciated? So bicarb binds up calcium. Calcium is an inotrope and it's also a vasopressor. Is there a therapeutic window for bicarb during like cardiac resuscitation? And then does bicarb worsen lactic acidosis? Because there's some in vitro evidence that it can. Anyway, I think I'll limit that discussion to that. That was probably too much for this podcast. Let me know if you enjoyed this discussion. I can get much deeper with a lot of the things that I talk about. So I'm just kind of trying this episode out to, that discussion today that was much deeper with more geared towards medical audience. Let me know if you liked that just kind of brief discussion. I can go in deeper into a lot of things, obviously. So yeah, just let me know. Email me at icudoctorecmo@gmail.com if you did not like this or if you did like this, because I'm happy to do more episodes like this. Anyway, so this whole discussion about sodium bicarb, whether you were kind of following along with some of the science and stuff or not, there's uncertainty in medicine, right? There's uncertainty of how to treat things. And there's for my medical career, what I've learned, and I trained and worked in a lot of places, like probably a dozen hospitals or more, different hospital systems. And at one hospital, what is like gospel, at another is like, if you suggest that same thing, you're like the Antichrist there. It's crazy. And I'm not talking about like huge things. Obviously, I think in the United States, medical care is pretty normalized across the board, but there's a lot of nuance, and a lot of this can get bogged down by institutional preference and protocols. And so it's been very interesting to see that one institution like, oh yeah, we give sodium bicarb to correct this one thing all the time, and then another institution, they don't even pay attention to that thing. So there's a lot of stuff in medicine that has to do with personal practice preferences and what that institution is used to doing. Culture is a huge force in how we think and operate, right? Culture dictates our behavior. So, and that includes hospital culture and work culture. Oftentimes we don't want to be perceived as the outsider. We don't want to be the voice of dissent, particularly if we're in a new environment, right? We want to have group bonding with the people we work with. So you don't want to be this dissenter. But, dissent and diversity of thought and having different opinions, these things are good, right? These things are good for patients. These things are good for patient care within reason, right? I'm not talking about crazy ideas. But yeah, that diversity of thought I think is very important. And this is why medicine is an art. I know that sounds like pretentious to say that medicine is an art, but the reason it's an art is so there's medical science that's backing what we do. Like as a doctor, I do understand some medical, science, but I'm not a scientist. I am not a scientist. I am very explicitly not a scientist. I don't do my own research. Now, some doctors can be scientists. I just particularly am not. I don't have a lab. I don't do my own research, which doesn't mean I don't publish literature. I do that, but I am not a scientist. And in general, doctors kind of aren't scientists. I'm a clinician. I'm a practitioner. I take the science that has been taught to me by people that have figured things out before I was ever born. I take that and then I learn that and I assimilate that into my brain. I assimilate that into my behavior, and then I apply that to someone's body. And that is an art form. That application of science to the human body, the actual the direct application. It has to be customized. It's inexact because there's so much gap. There's so many gaps in our knowledge. Even though, despite all the things that we know about medicine, there's so many gaps in our knowledge that this ultimately turns into an art form. And that's what a physician is. They're a practitioner of science. They are not directly a scientist. And this is why in medicine, consensus decision making is the best way to go about things. So when I'm in the ICU, we do rounds. Rounds are when the whole team goes to each patient. We talk about all of the data from that day, all of their labs, all of their vitals. Maybe they had chest X-ray, they had other imaging. What did the surgeons say? Blah blah blah. And then we get the nurse reports, the bedside nurse reports, what they have. We oftentimes have a nurse practitioner or a physician assistant that has their input. There's the charge nurse, there's respiratory therapy, there's physical therapy, there's speech pathology, there's the pharmacists. There's all these people. And so my job as the physician, the main attending there's also residents and med students, right? Is to not dictate what I want or what I think. The point of rounds is not for me to be like, okay, let's do this, this, and this, and this, or to sit back, hear people talk, and then bulldoze all over that, and then make the decision that I already had. That is not my job, and that is a bad way to go about things. And I have seen this. This is how some people operate, and I think it's a bad idea. My goal with rounds is consensus decision making. It's data collecting, data gathering, discussion, and making a decision together as a group of people that are taking care of this patient. Critical care and critical illness is too complex for one person to know every single thing about that patient, right? The bedside nurse has tremendous amount of information about that patient. They know how medications respond. They directly know how the patient's doing right away. They understand the patient family dynamics, how the patient is perceiving their care. They understand all of these things. And all of these things together, components together, are how we apply medicine to patients. It's not just taking a textbook and throwing that at the patient, right? That's not what medicine is. Consensus decision-making is the safest type and the most diligent type of medicine that we can apply to patients. And that is the point of rounds. There's no place for ego in the medicine and the ICU. When ego dominates, so like when one ego is dominating, that person doesn't know everything, and that person's going to make mistakes. And then if that person is punitive for others' mistakes, nobody is going to speak up. Nobody, and that's a patient safety issue. Right. So if you're in an operating room and the surgeon is a jerk and just dictating everything, blah, 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 and blaming everybody, and like that operating room is going to be silent. That surgeon's going to be either talking or just it's going to be silent. Nobody's going to speak up. If something is going wrong, someone like the scrub nurse or whoever may not want to speak up because they don't want to get yelled at. And then what happens? Something gets ignored. It turns into a problem. And then maybe that results in patient harm. There is no place for ego in medicine, and there's no place for ego in the ICU. All right, time to take a complete 180, and let's talk about our book discussion this week. So this is an old book. It was written in 1944. This is called The Road to Serfdom by Friedrich Hayek. Hayek, if you're not familiar, was an Austrian and British economist and philosopher. And he's known for his defense of classic liberal, capitalism, free market capitalism, and definitely against socialism and collectivist thought. He's kind of maybe the unofficial father of neoliberalism, and he was a big influence of right-wing economists like Milton Friedman. Hayek is extremely influential and still is today. So, and I always like to read books. I read lots of different types of books, and I like to read books that I think are counter to my viewpoint. I read lots of books like that, and this is definitely one of them. And I just wanted to read such a book that's so influential. So The Road to Serfdom is a difficult book to analyze because it was written in the 1940s within a certain cultural and political context. But I'm also reading it as a person living now in 2022, where this book has grown in prominence and it's taken on new meaning. So I'm going to give a brief review of what I think of this famous work in isolation, and which is followed by a critique of the modern significance and what I believe is the ultimate harm of the ideology that this book perpetrates. So unfortunately for Hayek, we have the benefit of the last 50 years or more, which serves as a repudiation of his doctrine. So I'm going to explain this. There is incredible irony that the very neoliberal policies that put in place in the 1970s, highly influenced by people like Hayek, have led to what could be described as a neo-feudal serfdom state. That's the biggest irony of this book. I'm talking about like the gig economy, techno-feudalism, which is a topic for another time. It's really important when talking about this book to nail down definitions. The Road to Serfdom is a polemic against socialism. Here's where definition is crucial. Socialism for Hayek specifically means total state control over the economy. So socialism for Hayek is probably what we would call communism today, maybe, depending on the definition. Now, I know there's maybe someone listening to this who's a proponent of communism who's screaming at me, right? But communism as it has been practiced, that's what I'm talking about. As it has been practiced by human beings, not the theory of it, but as it has been practiced. Hayek's conclusions about communism are fairly self-evident. That the way it has been practiced, in my opinion and in many opinions, has been bad, right? It's been bad. Having the government control the means of production and set prices, that is not good. To have the government have complete control over that. That you want control to be decentralized. Any governing body, whether it's the government or a private entity, having control like that is bad. That will lend to corruption and self-perpetuation of power 100% of the time. So Hayek has a lot of common sense, stating that, of course, the state must provide an appropriate legal framework in which free trade can operate to suppress monopolization and labor exploitation. He also discusses the inevitable disruption and monopolization that comes with tech advancements and how there should be state measures in place to step in when needed. I agree with him when he says that if the state had all control over the economy, they would have to assign arbitrary moral value to jobs, and that the government would be in total control of employment and salary and livelihood, right? That's bad. He states that this would inevitably lead to in-group, probably the racial dominant group, in-group exploitation of the minority group. Keep in mind, Hayek is highly, highly influenced by Nazi Germany at this time, and these are the conclusions he's drawing and witnessing within the borders of Germany at this time. The basis and foundation of his argument about central economic planning is sound. His slippery slope reasoning that follows is mostly entirely invalid. Hayek believes that any amount of social planning or social programs will invariably lead to totalitarianism. And those are his words. He makes this assertion many times with the debate fallacy of slippery slope reasoning. Hayek has, in my opinion, an incredibly naive trust in laissez-faire economics. The man actually believes in the Adam Smith myth of free markets. He believes that free markets operate separately from the state without recognizing the truth that markets have always been in collusion with the state. They are two sides of the same coin, in my opinion. He also went as far to say that social planning cannot happen because of racial and ethnic differences, and that the racial majority will never bow to the needs of the outgroup. He also incredulously believes that socialism is to blame for monopolized markets and has unfettered trust that free markets will limit monopolization, which is an absurd assertion to make. It was at that point when I was reading the book that I was kind of really rolling my eyes. Hayek doesn't see the truth. No society is purely capitalistic or socialistic. That's a fairy tale. These divisions are artificial. No modern day society is one way or the other. We like to act like it is. When we talk about capitalism, socialism, we like to talk like we're purists. But societies aren't like that, right? I mean, the global capitalism is the world order, obviously. But there's flavors and degrees of this. You have a state capitalism in countries like China, and then you have a more liberal, fake meritocratic capitalism in the United States. Anyway, not once does Hayek provide any support for his argument that even the meekest social welfare program will inevitably lead to totalitarianism. Basically, he starts on a foundation against communism and runs with it with really not a lot of evidence thereafter. It's important to review the impact of people like Hayek and Friedman and the Chicago Boys, which were a group of economists that went down to Chile that were trained with Milton Friedman that were highly influential in the overthrow of Allende and ushering in Pinochet. Anyway, people like Hayek helped the winds turn in the 1970s with the famed Powell memo and the Business Roundtable. If you're not familiar with those, check those out. And those redefined freedom. They literally redefined freedom, reappropriated the word as one thing: unfettered corporate latitude. The public listened and the public agreed. Voters agreed with this. Hayek helped usher in the age of neoliberalism from 1970 to present day. That's why this book is and these ideas are so incredibly influential. And what has been the fallout from all of this? Well, we have the greatest wealth inequality in perhaps the history of humankind, maybe. We have 40-year wage stagnation for half of all Americans with no reinvestment into the labor class that trickle-down economics is supposed to, help us out with. We have vast financialization, leveraged buyouts, increased shareholder power, stock buybacks, enhanced dividends, CEO golden parachutes. We possibly have the most monopolized markets that have ever existed in which the average American rents their labor for not even a living wage often. That sounds a little bit like a serfdom, doesn't it? And what about the social programs used by the US, the UK, other Western countries? Have we had a totalitarian regime suddenly fall out from this terrible socialism? Obviously not. Social welfare does not lead to Nazism. I'm sorry, Friedrich Hayek, it doesn't. It's complete nonsense. This is how you fabricate moral panic. This is how you fabricate wars that have destabilized, destroyed, and killed millions of people in Asia and South America. Communist panic perpetuated by the United States and the CIA. There is nothing more dangerous than an idealistic economist, in my opinion. I believe Hayek was well-intentioned when he wrote this, but his theories have been used to exercise extreme and flagrantly brutal economic and foreign policies that have resulted in poverty, war, and death for at least the last 50 years. I make no exaggeration. The Chicago Boy ideas have resulted in economic devastation and have enriched the very few. It is time to reject neoliberalism, the myth of free markets, and see the truth. Fascism can come from any ideology. We are living with the worst wealth disparity in history, directly from ideas promulgated by Hayek and his acolytes. It's time to move on. I do recommend reading this book if you want to understand a lot about history and a lot about how we got here. And I would recommend this along with Capitalism and Freedom by Milton Friedman as well. All right, let's finish up this episode with answering some questions from TikTok. Let's see. This one's from Monster Mama 03. Have you ever had a patient recognize you from social media? I haven't. It hasn't happened yet. I have someone from work recognize me about almost every day, and the reason is because it's all about what community, right? But my TikTok account is like a medical community, so if you're a medical professional, you maybe would be more likely to recognize me rather than a random patient that comes in. So that doesn't happen. And honestly, if it does, it might be a little awkward if they've seen all the stuff I put on TikTok, particularly talking about like how my car was infested with mice and I don't know, whatever. It's not that big of a deal, I guess. But no, it hasn't happened yet. I don't really want it to. Anyway. All right. Another question. This is from Indie Doggy. I have 2 months to study for the MCAT. Am I totally screwed? I think I actually answered this with a video on TikTok, but it's such a good question. I just wanted to touch on it. So the MCAT is a beast of an exam. Probably the hardest exam I've ever taken relatively. I've probably taken harder exams since, but I maybe was well prepared for them. The MCAT covers a bunch of topics, right? Biology and chemistry and physics and reading, not just reading comprehension, right? Reading comprehension is one thing. It really reading analysis and analyzing passages from literature and being able to interpret what that author would think about other things. So it's challenging. It's time constrained. And then you're studying for it typically while you're in college, studying for other classes. A lot of the times, not always. So it's a really challenging thing. I took the MCAT twice. I took it my first time. I took it while I was studying. I'm a chemistry undergrad. I was my senior year of chemistry, and I didn't take a review course, and I studied stuff on my own. And I did kind think of it as a dry run, which I think is a good way to think about it. And I got a score. The scoring has changed since then, so I don't really know how it relates. But my score was not a bad score, like probably amongst everybody who took the exam. But for someone who wants to be competitive and actually get into med school, extremely average. And I applied to med school that year, and I did not get in. I only got one interview at one school, and I did not get into that school. So I took the MCAT again. I took a prep course, and really took longer. Studied for probably 4 or 5 months. I'm not a studier who crams. I like to really prepare and know everything as much as possible. I'm obviously I'm like a fairly good test taker, but I don't think I'm like a brilliant test taker. I don't always knock it out of the park and stuff. Anyway, so the preparation paid off. I got a better score. I didn't get like a brilliant score, but that's fine. It was good enough to be competitive, at least with other people that were competing that same year, and I got into med school that year. So it just depends on the kind of studier you are. For some people, 2 months is plenty of time to prepare for the MCAT. Some people are just naturally really good test takers. Some people need more time. I needed a little more time. I don't think I'm a naturally good test taker. I think I need to train myself for that test, and I need time, and I need that to do well. So it really depends on who you are. 2 months might be enough. Some people might need 6 months. You need to gauge how you feel, and at that point, if you're ready to take the MCAT, you probably know what kind of test taker you are. So take that for whatever it's worth. All right, that'll wrap it up for this episode. Hope you enjoyed it. Please give me feedback again at icudoctorecmo@gmail.com. Follow me on TikTok, ICU Doctor, my handle, and then Instagram, I'm ICU Doctor TikTok. You can leave me messages on there. I do typically address and get to most people that ask me questions. Not always on TikTok because there's a lot, but people that message me on Instagram or email me, I get to almost all of it. Sometimes it can take me a while. So feel free to reach out. Thanks for listening. And please rate or review this podcast on whatever you're listening to let it grow. All right. Thank you.